everyone. I'll give everyone just a moment to get logged in. Thank you so much for being here today with us. Okay, I'll go ahead and get started. Thank you for being here today, and hello, everyone. I'm Bethany Burkhart. I'm the Director of Operations at the Allergy and Asthma Network, and I'm excited to welcome you to this afternoon's webinar. We've got a great session planned for you today. I'd like to mention a few housekeeping rules before we dive into today's program. All participants are muted to minimize background noise. Today's session is being recorded and will be available on our website within a few days in case you'd like to revisit it or share it with your family and friends. This webinar will last up to an hour, including time for questions at the end. Feel free to submit your questions in the Q&A box at any point. You'll find it at the bottom of your screen. Someone from our team is also monitoring the chat, so if you need help or have issues, just let us know. We'll do our best to answer any questions that you may have before we conclude. You'll receive a follow-up email a few days from now with additional resources and a link to download your certificate of attendance. Please note, while we are not offering continuing education credits or gift cards for this session, we will provide a certificate of attendance. With that being said, let's jump in. Today's presentation is titled Understanding and Managing Contact Dermatitis. Today we're going to dive into the world of contact dermatitis, a common skin condition affecting millions of Americans each year. It is also one of the most common skin conditions seen in both primary care and a specialty setting, yet it often remains undiagnosed or mismanaged. Contact dermatitis is commonly caused by reactions to certain products, materials, or environmental exposures. In this webinar, you'll learn what contact dermatitis is, what causes it, and most importantly, how to prevent and manage flare-ups in your daily life. You'll be guided through the process of identifying contact dermatitis, uncovering its potential triggers like everyday products or jewelry. Get ready to learn practical ways to avoid these triggers and establish a healthy skincare routine and help manage symptoms and prevent flare-ups. Without further ado, I'd like to introduce Dr. Amma Alexis. Dr. Amma Alexis is a clinical assistant professor of pediatrics affiliated with the NYU Langone Medical Center and Weill Cornell Medical College. She is a double boarded in allergy, immunology, and pediatrics and is a fellow at the American Academy of Allergy, Asthma, Immunology and at the American College of Allergy, Asthma, and Immunology and the American Academy of Pediatrics. She's also in private practice at Hudson Allergy. Dr. Alexis is passionate about educating and empowering individuals and families affected by contact dermatitis, food allergies, and advocating regionally and internationally. Thank you for being here today, Dr. Alexis. I'll turn it over to you.
Thank you, Bethany, for the kind introduction. So my name is Dr. Amma Alexis, and I'd like to welcome you and thank you for joining us today. And again, the presentation today is Understanding and Managing Contact Dermatitis. We'll jump right in. Let's see, I can advance the slides. There we go. Okay, great. So these are my disclosures, and I don't intend to discuss unlabeled or unproven uses of drugs or devices in this presentation today. So this will not affect the presentation today. So the learning objectives today includes expanding or reinforcing your knowledge in regards to, I'll give an overview. Let me just minimize this window here. Awesome. I'll give an overview of irritant and allergic contact dermatitis. Then we'll jump into a few clinical cases of patients of mine with contact dermatitis. We'll highlight a few important allergens, and then we'll also talk about patch testing and how to manage and avoid allergens going forward. So hold on. Okay, great. So let's start with a few definitions and some statistics. So contact dermatitis is an inflammatory skin disease in the eczema family. So in other words, it basically is a skin condition that occurs when your skin comes into contact with an allergen, especially if you're prone or have sensitive skin. So in my mind, we don't talk about it often enough, especially because contact dermatitis is the fifth most common, most prevalent skin disease in the United States. It's far more common than even acne, warts, or atopic dermatitis. So we usually talk about two different types of contact dermatitis. There's irritant contact dermatitis or allergic contact dermatitis. Both are managed by trying to understand what the triggers are, then by actively avoiding those triggers, and by managing active inflammation or managing actively treating the disease. So how often do we see contact dermatitis? In about 20% of children, sometimes even a little bit higher, and 20% of adults. Okay, great. So let's dive in a little bit more into irritant and allergic contact dermatitis. They're almost two different sides of a coin. So it turns out most cases are due to irritant contact dermatitis, actually up to 80%. It is triggered by external factors, and it's due to a non-specific response of the skin to direct chemical damage. So what does that mean? Any of us can develop irritant contact dermatitis under the right circumstances. So, for example, if we all start washing our hands about 20 times a day, we all may develop irritant contact dermatitis. Or if you think of a diaper rash, that is due to irritation due to an allergen in the diaper. So, what about allergic contact dermatitis? It's about 20% of all patients who have contact dermatitis. It is also triggered by an external factor. So this is a bit different though. Let's think about poison ivy. So the first time you touch poison ivy, nothing may happen, but at this point you become sensitized. Your body's like, I don't think I like this very much. So then on re-exposure, you then develop a rash, and that rash may take hours and sometimes even days to appear because the cells that cause allergic contact dermatitis are really slow. They're T cells. So it takes some time for those T cells to get to where they need to go. So a great example, again, of allergic contact dermatitis is either poison ivy or a nickel allergy. Let's zoom in a little bit in terms of irritant contact dermatitis. So the presentation can be heterogeneous, so it can present in many different ways. We can see redness or this discoloration. We can see swelling, scaling, and if it goes on for a long time, we can see fissures or what we call also lichenification. Again, this is a non-specific trigger. It's a non-allergic response. So we can all, under the right circumstances, develop irritant contact dermatitis. It can be acute, or if it goes on for a long time, it can become chronic. And it is often confined to the areas of contact with the irritant. So it doesn't go anywhere else. Lesions of irritant contact dermatitis heal really quickly if you remove the triggering agent. So we call that decrescendo. And common triggers are soaps, detergents, plain water, acids, adhesives, solvents, oils, disinfectants, kerosene, or gloves, just to name a few. So you have now developed this rash. It's not going away. So you can either see a dermatologist or an allergist. And there are a few things that we like to do. So we always start with by taking a good history and by taking a good physical examination. So these are questions that the doctor may ask you when you present. So we always start with onset of symptoms. How long has this been going on? Has it been a week or has it been several years? We want to know about the chronicity. And then we also want to know how often you develop the rash. Is the rash there all the time, or does it come and go? Very important are occupational exposures. So a big airline company a few years ago updated their uniforms, and all of a sudden, half of the workforce developed a rash, probably due to irritant contact dermatitis. So in this case, it was really important to let us know, you know what, I have a uniform at work, and we all got new uniforms, and now I have symptoms. What about wet work? What are those jobs, right? Those are cleaners, those are people who work construction. It can be nurses, hairdressers, where their hands are constantly wet with their work. Again, hairdressers and nurses often have increased numbers of irritant or contact dermatitis. And then we want to know about other exposures. Have you used a new cream, lotion, maybe a facial mask? Have you changed detergents? Do you get your nails done all the time? What about topical medication? Have you moved into a new environment, or have there been other major life changes? We like to ask about hobbies as well. Is there a new sport? Have you started playing a new instrument? Because we do see sometimes when patients change things, they can develop a rash to whatever they're now exposed to. And then we also would like to know whether you are treating the rash. Is anything helping? And often what I hear is that patients get better when they treat the rash, but then it comes back because they keep exposing themselves to that allergen. Well, on exam, we can again see redness, we can see discoloration, scaling. The patients often describe not just about an itch, but also about burning. We can see swelling and sometimes even blisters. And what's really important is the location of the rash. So The area around the eyes, the skin is quite skin insensitive. So we often see eyelid dermatitis. We can see reactions on the lips, the neck. There's a difference whether you have a rash in the underarm or the rash is around the underarm. We can see rash on the trunk, on the hands, and on the feet as well. So let's walk through a few cases. So let's start with this young lady. She is 7 years old and she just started first grade. And the teacher on the first days just kind of says how important it is for the kids to wash their hands on a regular basis. And the patient is like, yep, challenge accepted. And she washes her hands now a few times a day and she uses the soap at school. So after a few weeks, mom brings in the child and her hands are really dry and red. You can actually, if you take a look at the picture, the hands, you can see some redness here on the knuckles. The hand is really, really dry. And she says the hands burn and they're itchy. So what do you guys think is going on? It's irritant contact dermatitis from frequent hand washing with a harsh soap. So the goal was to say, you know what? You've done great, but you don't have to wash your hands that often. The teacher will let you know when to wash your hands. We used a different soap and we used a mild moisturizer afterwards, and the rash resolved without medical intervention. Okay, this is a case of a young woman. She's 23 years old and she does have a history of sensitive skin since early childhood. So she presents with a rash that's been going on for a few weeks. The rash will last for a few days. It kind of comes and goes. So the rash is redness and burning mostly on her face. Her eyelids are definitely involved and her neck. And again, the rash gets better and then it comes back. So she's having a hard time trying to understand what's triggering this rash. So on exam, her eyelids are really swollen and red, and we can see some scaling and some redness on her forehead, her eyelids, and her neck. On further exam, we also see a rash right around her nail beds. If you look a little closely, we can see some redness and some scaling right around her nail beds. And so we decide together that we'll place a patch test, and we'll talk about patch testing in a little bit. So my colleague, Dr. Fonacier, published this really helpful article where it kind of shows you where the rash is and what could be the trigger. It's really helpful. So on a patient, for example, we see some combination of her eyelids, her neck, and her face. And we can see this due to ectopic dermatitis, meaning that the rash is where the trigger is probably here, but the rash is somewhere else. So it's ectopic dermatitis from nail polish and acrylic nail dermatitis. So we see that quite often, actually. And so it turns out once we changed her nail care regimen that the rash all over resolved. This is another case of a young man. He's 22 years old. He has a history of eczema since early childhood. So he likes to use dye-free, fragrance-free products. And he's had a life change. Remember, we talked about life changes being a trigger. His rash started 8 weeks ago when he moved in with a roommate in college. So he presents his entire face is turned red. It happens almost every single day. And especially his eyelids are red and scaly. And that's exactly what I see on exam. So we test him as well. And in red here, you can see the three things that are highlighted in red are actually fragrances. So it's balsam of Peru, hydroxyperoxidase of limonene, and fragrance mix number one. So taking a further history, it turns out that his roommate loves to spray cologne in the shared bathroom. So when he walks into the bathroom every single day, he's exposed to fragrance on his face, which when we look back at a really helpful chart from Dr. Fonacier, we see you can get a full face rash, which we see in our patients with airborne contactants, facial cleansers, and makeup foundation. On to the next case. So this is a middle-aged man who has no past medical history, nothing significant. And he has now a rash that started about 4 weeks ago. He says the rash is it's really uncomfortable. He's itchy all the time, but it's also like this burning sensation. He's not taking any new medications. And we see really these red patches all over his trunk. So we patch test him. And it turns out he tests positive to fragrance mix number two. Now, this one's an interesting one because it turns out we realized that he's reacting to his detergents. Now, detergents can do one of two things. You can either get allergic contact dermatitis. So yes, it was the fragrance that caused the reaction, or you can get an irritant contact dermatitis. So that's just due to an irritant in the detergent, not necessarily an allergy. So the plan was to change detergents to dye-free, fragrance-free, and to add an extra rinse cycle. And again, the rash resolved. This is a case of a young woman. She's 31 years old. She has type 2 insulin-dependent diabetes mellitus, and she has a red circular patch on her arm. So this is the reason why. So continuous glucose sensors and insulin pumps are really amazing. They've really improved the quality of life of our patients with insulin-dependent diabetes mellitus. But it turns out that almost 18 chemicals, including 10 acrylates, which are glues, have been reported to cause allergic contact dermatitis. So if this is the case, have a conversation with your allergist or your dermatologist. On to the next case. It's a case of a young woman. This one's interesting. So she presents with a rash, an itchy rash on her neck, always on one side. The rash comes and goes, it burns, it's uncomfortable, and also doesn't look very nice. She does have a history of sensitive skin. So, we chat and we talk and we discuss what could be the cause of this rash, and we couldn't figure it out. So again, we decide to patch test. And she let me take a picture with the offending agent. So it's one of her bags that's causing the rash. So on patch test, she tested positive to potassium dichromate, which we can see in tanning leathers and in green pigment for textiles. And there it is. So, now that she's wearing the bag, it's very obvious, but it really wasn't obvious before, especially because contact dermatitis doesn't happen right away, right? It happens after a day or two or three. So let's say she wears the bag on a Friday, she's going to be fine, maybe on a Saturday, but on Sunday, she now develops a rash. So it's not always easy to put together. All right, and here are another few examples of this fantastic article. So if you just have upper eyelid involvement, it may just be due to an irritant. If you have eyelid plus facial involvement, it could be due to a facial cleanser. If you have eyelid plus scalp or forehead involvement, it could be due to a hair product that you're using, such as a dye, a bleaching agent, setting lotions, sprays, gels, or a mousse. And if it's the upper and lower eyelid that extend beyond the orbit, if you have involvement there, it can be due to shampoos and or conditioners. So I keep talking about patch testing. Let's take a closer look at the patch test itself. So the way we figure out exactly what you are allergic to is to patch test. The way we do that is we place these patches on your back, and they have to stay on your back for 2 days. So what we often do is we put them on a Monday, we take them off on a Wednesday, and then we document any reactions, and then we read the test again on a Friday. And sometimes, in some cases, we read it one more time 7 days after placement. So here's an example of two of these patch tests. On one side, we see the true test. The true test tests for 35 allergens, and it's approved by the FDA for patients 6 years and older. And in the middle here, we see the North American Standard Series. It tests for 80 allergens, so it casts the net a little bit wider. And often the question I get is, can we just do lab work? We can't, because we're looking for T cells that we can't capture. These specific T cells we can't capture through lab work. Another question is, what about the prick test? No, we look for IgE with a prick test, where we prick your skin and then we wait 15 minutes for a response. We can do that with foods. We can do that with environmental allergens like dust mites, cat, dog, pollen, mold, for example. Again, this is a completely different test. This is called the patch test. So we just had this amazing article from Dr. Fonase. What do we need a patch test for? So it turns out in only 30 to 50% can we really understand what's causing the patch test just by history alone. Meaning in 50% we would miss what the underlying allergen is. And there are different patch tests. We just looked at the true patch test that tests for for 35 allergens. Then we have the American Contact Dermatitis Society Core Allergen Series that tests for 80. We have the North American Standard Series, that's what we do in the office. It tests for 70 to 80. But there are other patch tests as well. We have specialized series where we can just test for metal or for dental allergens. There's a hairdresser series, there's a fragrance series. So if we can capture what's positive on the North American, there are some specialized series that we can kind of delve into it a little bit more. So what are we looking for? It turns out 3,000 allergens have been reported to cause allergic contact dermatitis, but it's usually a few dozen that cause most of the reactions. And what are those? Those are the most common allergens. Those are metals, fragrances, preservatives. Preservatives are great. They make sure that our personal products don't become moldy. Hold on, those become moldy. I'm just going to move this to the side 1 second. They don't become moldy. That we can see textile dyes, rubber, chemicals, topical medications, sunscreens, or acrylates, which are glues. I love a poll questions, and we have one. Here is the question. What is the most common primary site of contact dermatitis? So I'm going to just move that right back here into the middle and give you a little bit of time to respond. If you think about, if we go through our day, what do we use a lot? Where do we come into contact with allergens throughout the day? So I'll let you guys decide what you think would be best. We'll give it another few seconds so you can make up your minds, whether it's the hands, the feet, got 0 for feet so far, the face, or the back. Ah, we got 1 for face, for feet. Okay. We'll give it 1 more minute. Okay, so well, the winner is hands. So let's see whether that is true. Let's go on to, let me close that window here. We set hands number 1, face number 2. Let's take a look here. Let's see, let me advance my slides. There we go. So we just asked that question, and here's the answer. So the North, oops, no, there we go. Very good. We have hands here. Hold on, let me move that to the sides. So the North American Contact Dermatitis Group is the largest group in the US that actually publishes patch test results. And they just published this article just a few weeks back, where they looked at patch test results from 2021 to 2022. They looked at about 3,000 patients, about 3/4 were white, 3/4 were female. The average age was 45 years. And the most common primary site are the hands, that's correct, followed by the face, and then followed by having a generalized scattered pattern. Okay, hold on, I'm going to advance these slides. There we go. They also published what patients reacted to. This is the top 10. Again, this is for the year 2021, 2022. So we have 3 big categories. Number 1 is metals. It turns out nickel holds that number 1 spot for a very long time. So in the top 10, we have 3 metals. We have nickel, we have cobalt, and we have gold. We have 3 fragrances. We have hydroxyperoxidase of linalool. We have fragrance mix number 1 and balsam of Peru. And we have 3 preservatives. Now, these have long names, so we love to use abbreviations. So it's MCI, MCI, MI, and benzisothiazolinone as well, 3 preservatives. All right, so my colleague, Dr. Yu from Boston, sees a lot of pediatric patients who he patch tests, and so he published his results in regards to the pediatric data that we see here and highlighted in the middle. The picture here we see of a young lady who responded with a rash in her armpit when she started using deodorant. So what do we see in the pediatric population? Nickel, again, is number 1. We see fragrance, cobalt is a metal, balsam of Peru is a fragrance. Neomycin and bacitracin are topical antibiotics. Propylene glycol is a preservative. Compositate falls under the fragrance category. Formaldehyde is another preservative, and gold, again, is a metal. So it's kind of similar, but we see with different exposures, we may get different numbers of what patients respond to. And Dr. Maybach published this really helpful article as well. It looked at patch testing in patients with skin of color. We do see similar rates overall of allergic contact dermatitis in white, African American, Hispanic, and Asian patients. But we do see different allergens that we see in different populations, and we do believe that's due to different exposures. But he also made a comment that we do have limited data in regards to African American patients, Hispanic patients, and Asian patients. They're not as frequently patch tested. So what do we see in African American patients? PPD, paraphenylaldiamine, is found in black hair dye. And where are patients exposed, you ask? That's right, when we dye our hair, right? So that's number 1, the number 1 allergen. Balsam of Peru, which is a fragrance, bacitracin, fragrance mix, and nickel is in the top 5 there. In Hispanic patients, we see rubber accelerators, nickel, formaldehyde resin, again, PPD, and neomycin. And in Asian patients, again, nickel is up there, fragrance, and potassium dichromate. So let's talk about let's highlight a few allergens. So we said nickel is worldwide number 1. Nickel is the leading contact allergen in most industrialized countries worldwide. Nickel is a durable, inexpensive metal. It is present in many silvery objects. and it's encountered pretty much every single day. So I always ask about, can you tolerate your earrings? Have you ever had issues with earrings? And that's often like, yeah, I can't unless it's 100% gold. I can't tolerate it. We see issues with rings, necklace clasps, the jeans belly button, and that's the picture that we see here, but also like eyelash curlers, tweezers, and metal instruments. This is a great resource I like to share with my patients. This is the nickel alert kit. The way this works is you can buy this little fluid here, you put in a Q-tip, and then you rub it on anything that is silvery, shiny, because silvery things don't come with a tag. And if it turns pink, it releases enough nickel for you to kind of for it to cause a reaction. So we have the nickel alert kit, and we also have the reveal and conceal. It works in a similar way in that you rub the little reveal nickel marker, and if it turns pink, it contains nickel. But they also have this little conceal container where you can kind of cover your nickel, and then you're probably able to tolerate whatever you are using. So that's kind of nice to have as well. All right, fragrances. So fragrances are natural or synthetic substances, and they're really used to impart an aroma to a product, usually a nice one. Perfumes are then mixtures of fragrance substances, which on evacuation release a pleasant scent. So it turns out on the patch test are at least different or multiple fragrance mixes. We have fragrance mix number 1, we have fragrance mix number 2, we have balsam of Peru, and then the new kids on the block are hydroxyperoxidase of linalool and limonene. Where can those be found? In a lot of personal care products, in soaps, creams, deodorants, shaving creams, sunscreen, baby wipes, scented candles. And this is a new one. It's a new thing that if you walk into some hotels and even some just apartment buildings, that they now circulate fragrance through the ventilation system. So when you walk into a place, it smells very pleasant, which is great. Unless you have contact dermatitis, then it's not great because you can react, and a patient definitely react to that exposure as well. Acrylates are polymers, and they are used in glues, in all kinds of glues. And we use glues pretty much all the time. One of them is just super glue, but another one is HEMA, which a lot of my patients are familiar with because it is used in nail polish. And it turns out you have a ninefold increase of an allergen risk for if you're a hairdresser or a beautician compared to other patients, so much so that 2-HEMA has been restricted in cosmetics for use for only to be used by professionals in Europe. And again, exposure, you see the first 5 exposures are all nail related. So artificial nails and long-lasting nail lacquers and gel nails and shellac gel. And also it can be found in industrial glues, in dental fillings, in adhesives, orthopedic cements, in tape, artificial islands, implants, which is so interesting, in soft contact lenses. So it can be found in different spaces. Neomycin. Neomycin is a topical antibiotic. It is often in the top 20 in patch tests. And you can actually buy it over the counter in a triple ointment, neomycin, bacitracin, and polymyxin B, those 3 antibiotics. So often patients who are responsive to neomycin often also react to bacitracin. And again, you can find it just in the antibiotic ointment or cream, in bandages if they add that to the bandage, or in gauzes, wound care ointments, scar treatments, ulcer preparations, medicated powders, dental root canal fillings. This is important too, right? And then interestingly enough, also in pet foods and veterinary animal feed as well. All right. So, you've gone to the doctor, you've been patch tested, you went through this whole week with these band-aids, big band-aids on your back. We figured out what you're allergic to. So now what, right? You want to avoid the allergens. So there are fantastic resources to help you do that. This is from the American Contact Dermatitis Society. They have this really fantastic database. It's called the Contact Allergen Management Program, or CAMP for short, which they recently overhauled. It's now CAMP 2.0 with a really user-friendly interface. Your allergist or dermatologist has to be part of the American Contact Dermatitis Society to be able to access this, but they have these fantastic handouts that talk about what you're allergic to, what are different names for that allergen, and where you can find it. And then you can plug in whatever you tested positive to into this database, and it will push out this fantastic list of safe products that are safe for you to use. And you can email that to the patient. There's also an app. So once you have your codes of the things that you tested positive to, you can use that app and you go to the store and make sure that you only buy products that don't contain what you tested positive to. Another great resource is called SkinSafe. It's another website which is great, another big database that they list their products in terms of what allergens are inside these products. So if you're allergic to fragrance, you can search by fragrance, you can search by nickel, you can search by preservatives, you can search by dyes. It's really helpful. I think they have a free, yeah, you can get free access, and they also have like premium benefits as well. So you don't have to be a member to join this. It's also a really great and helpful resource. All right, this is another great article by a colleague of mine. I did spend all this time talking about how important it is to patch test, but it turns out, you have to take 3 days off to be patch tested, and you may live really far away from your allergen, for your allergist or from your dermatologist. Or it may take you a long time to get in to be patch tested. And there are a few things you could do while you're waiting to be patch tested. So we talked about the eyelids being very sensitive. So if you have eyelid dermatitis, it could be due to a commonly implicated allergen, could be metal, so nickel or gold. Um, Fragrances, acrylates, which we just learned are glues, balsam of Peru, which is fragrance, or MI, which you also learned is a preservative. So things you can do by yourself is you can consider a trial of fragrance or MI-free face and hair care products, and avoiding of rings, earrings, and also make sure you use eye drops without preservatives. What about lip dermatitis? We see lip dermatitis so often, and contact dermatitis is almost always an afterthought. But think about fragrances, balsam of Peru, phthalates are preservatives, or even just sunscreen, right? Again, that can be an allergen as well. What can you do? You can switch to plain Vaseline lip balm, use Favor or flavor are fragrance-free cosmetics and oral care products. And what about your hands? The most common sites. Again, the most commonly implicated allergens are fragrances, surfactants, rubber accelerants, and nickel. What can you do? A trial of fragrance-free soaps or hand sanitizers. And if you have to use gloves, switch to vinyl gloves. So lastly, therapy. Therapy is fairly easy. It's a treatment for contact dermatitis. Really, you really want to understand what the trigger is of your contact dermatitis. And I thought this is really interesting. The rash may take up to 6 to 8 weeks to resolve if you stop taking away that allergen, so it doesn't just resolve overnight. And really at the heart of contact dermatitis is really avoidance of triggers if you can. Other things you can do, obviously, is protect the skin barrier. You use, short, lukewarm showers. Use fragrance-free, dye-free moisturizing creams and/or ointments. If there is a lot of inflammation, we sometimes treat with topical therapies like a topical steroid. Or if there's really widespread inflammation, we can sometimes also use a topical, an oral steroid to treat. So a systemic therapy. So let's take a look. Oh, another poll question. Okay, great. So what percent of the population suffers from contact dermatitis? I think I mentioned that at the very beginning. Let's see whether you guys paid attention. Our options are up to 40%, up to 30%, up to 20%, and up to 5%. And this was at the very beginning. You may have been there, you may have missed it. But I had this little figurine with a mom and a child, or an adult and a child at the beginning, when I mentioned how many people develop contact dermatitis. We'll give it a few more minutes to see. Neck to neck between 40% and up to 20%. Let's see. Well, it's interesting because we're asking about up to. I give just a number. So let's see what we get there. Oh, it's evenly split, I think. It's evenly split up to 40, up to 30, and up to 20. I said 20%. I said 20%. So there is something to think about. About 20% of patients. In kids, it's a bit higher, but in adults, it's about 20% of patients, the general population. Okay, awesome. So, yeah, hold on. Okay, great. So in summary, contact dermatitis is a common chronic skin disease affecting up to 20% of the population. Allergic contact dermatitis prevalence is similar across all patient populations, old and young. The location of the rash and the exposure history can give us very important clues, which are absolutely helpful, but the patch test, which goes in your back and stays in your back for 2 days, really is the gold standard in treating allergic contact dermatitis. I'd like to thank you very much for taking the time and joining me today. And I think we have time for our Q&A session.
Yes, thank you so much, Dr. Alexis, for that insightful presentation on managing and understanding contact dermatitis. It can be a tough diagnosis for patients to understand. Now let's dive into a few questions. And if anyone has some questions, please put them in the Q&A box and we can try to get to those. The first question is, do allergies to red and yellow dyes cause dermatitis?
It's interesting. So red and yellow dye specifically are not on the patch test, but dispersed blue is, and dispersed orange, those are common. So dyes can cause contact dermatitis, specifically yellow and red. That could be an irritant versus truly allergic contact dermatitis. And the best way to figure that out would be, again, to patch test. But yeah, dyes can cause contact dermatitis for sure.
Great. Thank you. And can
Mhm.
food allergies trigger dermatitis, or is it only for skin contact?
So it's interesting. Um, so I have a few patients who, when they peel shellfish, when they peel shrimp, they develop a contact dermatitis to the shell, but they can eat the food without an issue. So that we see. Also, I mentioned balsam of Peru, which is a fragrance which can be found in some foods, including ketchup or including sodas like a Coca-Cola or a Pepsi. So some foods, when taken internally, can cause contact dermatitis. Another interesting one is nickel. So most patients who I see who have a nickel allergy actually have to touch the metal to have a reaction, but there are a few patients who are really, really sensitive that if they eat foods that are rich in nickel, they can develop what's called deshydrosis, where they get these clear, itchy bubbles on their hands. So yeah, a few foods actually can cause contact dermatitis. Nickel is interesting in terms of you actually have to eat the food. Shellfish is interesting in that you can peel it, you get a rash, but you can actually eat the food, you're not truly allergic. So yeah, foods sometimes can cause contact dermatitis. And actually, how can I forget in babies? I see it all the time in young kids, especially if there's a little bit of eczema, right? So there's sometimes the question, you feed the food, it's a really messy meal, and then there's a rash wherever the food touched the skin. So that is contact dermatitis, not true food allergy. And I don't want you to stop giving the food because the child is not truly allergic. Another great question. So thank you for that. So yes, we do see contact dermatitis to foods.
Okay, we have a new question. Are
Yeah.
like women's underwire bras, have you ever seen that as a trigger for contact dermatitis?
Yes, I have. And sometimes it's tricky because, the underwire bra is symmetric and the rash isn't always symmetric. But yes, I've seen that. That can be several fold. It can either be the metal or it can be the material itself that can cause, like it's the rubber within the material that can cause contact dermatitis. So that's a yes. See your friendly neighborhood allergist or dermatologist. Absolutely.
Thank you. Are there safer alternatives to maybe some steroid creams or long-term management that you've seen or anything like that?
And the goal is really to identify the trigger and get rid of the trigger because the rash will only occur if you get into contact with that allergen. So once you can identify the trigger and you actually don't, if you can, avoid the trigger, the rash will go away and stay away. That's really the goal, especially with patch testing. Um, there are so this is where it gets tricky. There are other non-FDA approved therapies to treat dermatitis in general, absolutely. And we have a lot of options in terms of steroidal and non-steroidal options. But in terms of FDA approved, it really is avoidance of the allergen. But yeah, to your question, we have non-steroidal creams that treat dermatitis. Yes.
Okay, thank you. Um, this one's just an advocacy question. How can a patient advocate for themselves if a rash keeps coming back, or advocate for themselves at their allergist office?
Yeah, I think advocating for yourself is always, I think, is fantastic. I think coming in with a good history is always helpful. If you can explain to your provider how long the rash has been going on, that it keeps coming back, where on your body you get it, and if you haven't seen a specialist, get a referral or see a specialist. because as allergists we see this all the time, and it's always funny how patients are like, have you ever seen this? I'm like, yeah, I saw like two just like you today. So to us we see this all the time. Some providers may not see this all the time. So if you're having a hard time with your local provider, see whether you can see a specialist who can help you. So speaking up and just explaining that this has been going on for a long time, or even not even a long time, and trying to want to understand why you get the rashes, I think is very helpful, which is interesting, which is definitely there for contact dermatitis. For atopic dermatitis, that's a whole different ball game. So it always depends on what kind of rash you have.
Okay, thank you. And one last question. You mentioned
Sure.
switching to Vaseline for lip dermatitis. Are there any Vaseline allergies?
I haven't seen one yet in 16 years. So really,
Okay.
Vaseline is really inert. Aquaphor is interesting because Aquaphor contains lanolin, and I've definitely seen reactions to lanolin. CeraVe Healing Ointment does not contain lanolin, so that would be an alternative to Vaseline. But I have yet to seen a reaction to Vaseline. It can be occlusive and sticky in the summer, especially when patients are sweating a lot. But in terms of lips, we are always, as allergists, very cautious on what we put on our lips in terms of lip balms, lip glosses, things that smell nice. It can all cause contact dermatitis. Yeah.
Okay, well, thank you so much for that. We really enjoyed your talk today, and thank you again for this insightful webinar. And you'll receive an email shortly. All participants certificate of attendance, some information on today's webinar, along with some resources, and an evaluation. So thank you for today's presentation. I think maybe Linda would like to say something.
Oh, hi,
Uh,
Dr. Alexis. Thanks for this really good presentation. I had a little kid with food allergies for all those years, and I was reading labels religiously. And here I'm reading labels again because I found out I'm allergic to propylene glycol, and
Mm,
it's in all kinds of cosmetics. So before I buy
mm,
mascara, before I buy, I think it was like eyebrow something,
yeah,
their hair
yeah.
products in it. It's
Wow.
crazy, but it's just one of those things where label reading is kind of keeping me from having it again.
Isn't it so powerful to know what you are allergic to? So it takes the guessing out of it. You know exactly what to look for. And if you use products without propylene glycol, which is a preservative, you should be fine.
Yeah, that's what I do now. So it's a little
Yeah.
crazy, but here I am reading labels again.
No, I think it's very powerful to know what you are allergic to, and so you can avoid it. Yeah.
Well, thank you for this wonderful presentation. Really appreciate it. It was very informative.
Thank you, everybody, for joining. Have a great day.
Bye, everyone.
Thanks,
Bye.
Bethany.